Without further ado, I would like to introduce our speaker today, and the topic of today's speaker is the use of implementation science theory to increase the uptake of best evidence amongst healthcare providers. Um, the content of this particular seminar will be about the implementation science. How does it transfer the high quality knowledge produced by research into daily clinical practice? The ultimate goal is to improve the quality of health services provided by healthcare providers and patient outcomes, which including pain or disability. This seminar will discuss how we develop the guidelines, or how Dr. Zoubi developed guidelines and use theories, models, frameworks to change the healthcare providers' behaviors and promote uptake of best practice. Regarding Dr. Fedi Al-Salbi, he is an implementation scientist. He attained his BSc in physiotherapy from Jordan University of Science and Technology and professional MSc degree from New York Institute of Technology. He completed his research-based MSc, PhD, and postdoc training in rehabilitation from McGill University. He practiced as a licensed physiotherapist for several years in Jordan as well as Canada, focusing on musculoskeletal conditions. He taught several courses on musculoskeletal management at McGill University as well as the Hong Kong Polytechnic University. Dr. Al-Salbi's research focuses on developing and implementing clinical practice guidelines for the management and of musculoskeletal conditions such as low back pain, neck pain, and spinal stenosis. He adopts theory-guided approaches to design and implement complex strategies to increase the uptake and use of guideline recommendations in clinical practice. Additionally, he develops robust measurement approaches for constructs around evidence-based practice using modern measurement theory. The ultimate goal of his research is to bridge the gap between what we know and what we practice in rehabilitation. Dr. Al-Salbi has received numerous academic awards, fellowship, grants from several renowned research agencies, such as the Center for Interdisciplinary Research in Rehabilitation of Greater Montreal, the Canadian Institute of Health Research, CIHR, and research and at Edith, Richard and Edith Stroff's Foundation of Canada. His research has been published in recognized peer-reviewed international journals. So I will pass the mic to Dr. Al-Salbi, and please turn off your mic for the rest of us and listen. Thank you.
Well, thank you, Dr. Wong, for the kind presentation. And I would like to thank all of you for coming to this talk this afternoon. Also, before I start, I would like just to acknowledge Dr. Hector Chang and Dr. David Mann for their kind suggestion to provide a lecture about my research. I will share the screen with you first. I hope that you can see that. Let me know if you can see it or not, please. Yes, no?
Yes, we see it.
Okay, great, thank you. So as Dr. Wong mentioned that this talk will be entitled as the use of implementation science theory to increase the uptake of best evidence and recommendations from the clinical practice guidelines among healthcare providers. Today, I will be talking about how we create evidence, what's the meaning of evidence, research evidence, how we develop the evidence, and how we conduct evidence-based practice methodologies, and what are the evidence-based practice measures that we need to develop in terms of improving the uptake of evidence-based practice recommendations. Also, we will be talking a bit about how we develop clinical practice guidelines and how we implement the recommendations, the product of these guidelines into clinical practice using knowledge translation, using knowledge diffusion and dissemination and implementation science. Just before I start, I would like to remind you about the simple definition of evidence. Evidence is considered a proof that's supporting a claim or a belief. In healthcare settings, evidence refers to the effective intervention that showed to be able to achieve an outcome that will create sustainable changes in the health of the patients of the targeted population. And usually these kind of research evidences, we find them published in peer-reviewed journals, books, and governmental reports. So why do you think we need evidence? Actually, there are three reasons, important reasons why we need evidence. Just I would like to share with you this picture that goes back to 1946 in Eastern Europe, where the therapists were treating people with low back pain using a bear. And when we compare that with the recent practices of the physiotherapy, the current practices using the manual therapy, the exercises, the stratified care approaches such as McKinsey and StartPack screening tool, both of them are effective, by the way, in terms of the results for the patients. But the difference between the two practices is the safety. We are looking for safe practices and not harmful practices. The second reason is the accumulation of publications. Yesterday, I did this search on the PubMed. I used two keywords, rehabilitation and musculoskeletal. And I did the search from inception till 2020. In total, I had about 18,000 publications. If you look to the 2020 alone, we had about 2,100 publications. And if you compare that with the publications from the past century, the whole 20th century, plus the first 5 years of the current century, the total publications was 2,200 publications, which is almost close to 2020 publications. That means in 1 year, we are producing a huge amount of knowledge compared to what we were producing in a whole century. Therefore, we need to reduce these amounts of knowledges and provide summaries for the clinicians so they can digest these results. The third reason is the importance of having the best quality and not inequality of the evidences. And I'm pretty sure that you are all familiar with this hierarchy of knowledge level. This pyramid represents how we look to the evidences, going from the bottom, which is the weakest evidence, to the top tip, which is the strongest evidence. And we can divide them into two levels. We have the subject level of data, or which is ranging from expert opinion till randomized controlled trials. And these kind of evidences are sometimes we call them unfiltered kind of data, because these data were not critically appraised in terms of the quality. In the top tip of this pyramid is the systematic reviews, meta-analysis, and clinical practice guidelines. And these are the most important ones because these are filtered data. That means we appraised the quality of these evidences and we can judge on the quality. This recommendation, for example, of high quality, low quality, moderate quality, and so on. And based on that, we can make a recommendation or suggestions for the clinicians. So the next question is it all about evidence or it's more than just evidence? Are there any other factors controlling them, digesting or implementing the evidence into practice? Actually, I like this statement that was produced by the Canadian Health Services Research Foundation, saying that evidence is the basis of the message, but not the message itself. So when you think about evidence-based practice, it's an integration of the best available evidence that's coming from research findings with the individual clinical expertise from clinicians and the patient values, religion, culture, and preferences to inform the clinical decision-making. So it's not only about evidence. We have other factors here. We have the clinician and the patient's factors. So how can we move the evidence then to the practice? The simplest way to answer this question is to say that by knowledge transfer or knowledge translation, just take the knowledge and give it to the clinicians. But it's not that simple. There is a nice systematic review that published in 2010 showed that there is more than 50 ways to say knowledge translation. Each one of these knowledge translations have different definition and different methodology accordingly. I will share with you a few of these definitions. World Health Organization define knowledge translation to be the synthesis, exchange, and application of knowledge by relevant stakeholders to accelerate the benefits of a global and local innovation in strengthening health systems and improving people's health. If you look to the definition of the knowledge, it was kept proud, making it very proud because we are talking about World Health Organization. They are caring about more than only health. There are other factors as well. But if you think about the knowledge translation in the local context in Hong Kong, University Grants Committee defined knowledge translation. Well, first of all, they used the key term knowledge transfer, but not knowledge translation. And they defined knowledge transfer to be the systems and the processes by which knowledge, including technology, know-how, expertise, and skills are transferred from or between higher education institutions and society, leading to innovative, profitable, or economic or social improvements. If you look to the definition of the knowledge, it was limited to technology, know-how, expertise, and skills. And if you think about the movement of the knowledge, it was limited between the higher education institutions. That means researchers from universities have to be involved, and the society. I think one of the great definitions, you will find hundreds of definitions. It depends on the institution. Each institution, even here in PolyU, we have different definition for the knowledge transfer. These definitions are based on the objectives of the institutions. One of the great definitions that I found in the literature is that knowledge translation is getting the right information to the right people at the right time and in the right format so as to influence decision-making. I think this is very brief but strong definition. So how can we translate knowledge? What are the methods to do that? I will share with you 3 methodologies that we use, and these are the most common methodologies. The first one is called diffusion, or let it happen. And this is a passive process that all of us as researchers do this kind of knowledge translation. When we conduct a study, we have the findings, then we disseminate these findings among the researchers, educators, and educational policymakers using the traditional methodologies, such as presenting the findings in the conference, submit the manuscript to peer-reviewed or non-peer-reviewed publications, and we could use social media platforms, such as posting the results on the Facebook or tweet it on Twitter, or any kind of media platforms. The second way, it's more likely to force it to happen or make it happen. It's called dissemination, and sometimes in the literature they refer to it as KT, knowledge translation, which is an active way to transfer the knowledge, targeted knowledge. That means it's designed for targeted population, targeted audiences, to increase their use of evidence and the uptake of the recent findings of the literature to bridge any gap between research and the practice. I will give you 2 examples about that. These are end of grant KT and integrated KT. The end of grant KT is simply that when you apply for fund, you get this fund, and then you conduct a study, you get the results, then you submit these results to the funders. You submit these results as a summary. One of the examples for that is clinical practice guidelines. Think about Hong Kong Physiotherapy Association. They might fund guidelines for the management of osteoarthritis, for example. They will provide fund for researchers. They will develop the research. They will have the results, and then they will send them summary or the guideline to the association, who are able to post it online, to invite the members for a conference, to send private emails for all the members of this association. Again, it's targeted audiences. The second method or example is called integrated knowledge translation. And sometimes we call it participatory research or collaborative research, in which the researchers and the stakeholders, the end users of the knowledge, are together working to do the whole study. That means you bring the patient, the policymakers, the professionals, and maybe the professional body representatives together. You set the research question, you decide what's the best methodology to answer this question, and then you collect the data together and interpret the findings. And at the end users will disseminate the results on themselves. This is exactly like what happened if a hospital would like to improve the quality services, for example, the physiotherapy services, and they found that they are not updated. So they ask one of the researchers to come and share their knowledge and research expertise with them so they can do such kind of collaborative research. The third method, and this is the most interesting one and the most used one these days, is the implementation science. And it's very interesting because it uses robust methodologies, it uses theories, it uses models and frameworks to change not only the knowledge, but the behavior as well of the community, the people, the professionals, or the patients, and to promote the uptake of the research into practice. There are several examples about that, but the most citable one and the most used one is the knowledge to action framework. And I will spend the rest of today's talk talking about this framework. Now, this framework consists of two phases, two major phases, and in each phase, there are several steps. There is the knowledge creation funnel, which is in the center, as you see, and there is the action cycle, which is this cycle. In the knowledge creation funnel, we create and produce knowledge. And whenever we finish, we use the action cycle to implement this knowledge and to make sure the implementation is sustainable over time. So let me talk about each one of these major phases and their relevant steps in more details. For the knowledge creation, it starts with the knowledge inquiry, which is as simply as when you have a research question in your mind and you just do a primary study, such as randomized controlled trials. Think about, as a researcher, you think that acupuncture is working when you combine it with manual therapy, for example, against usual care. So you decide to do a randomized controlled trial and you get an answer for your question. It works or it does not work. Then we synthesize the knowledge. That means we looked for all published data, such as the RCTs or non-RCTs, and we make summaries using scoping reviews, narrative reviews, systematic reviews, or meta-analyses. All right. After that, we create products because we cannot produce. In the literature, you will find hundreds of thousands of summaries of systematic reviews and meta-analysis. So we need to provide a product, something simple for the clinician or the patient to digest. And this is this is the highest level, which is the filtered level of data, where we appraise the quality of the studies and we decide to give like 1 or 2 pages of recommendations for the management of a problem like low back pain or breast cancer or neck pain or whatever. All right. So at the end of this knowledge creation funnel, we will implement the findings of this 1 or 2 pages. But before we go to this cycle, I would like to share with you how we develop clinical practice guidelines. So this graph represents, in summary, what we do. The first thing is we convene guideline panel. We gather expert in methodology, measurement, professional body agencies representatives, such as Hong Kong Physiotherapy Association representative, patient representatives, and we ask them all to sit together and choose what's the medical condition that's the most prevalent or the most costly for the healthcare system. For example, for physiotherapists who are managing musculoskeletal conditions, number 1 condition is low back pain, then neck pain, then osteoarthritis for hips and knees, and so on. And you go in this way. These are based on the prevalence. But if you think about the cost, think about oncology, for example. Could you please just mute your mic? All right. So the next part, after we choose what's the medical condition, is to develop key questions using the PICO format for each one of the assessment and treatment and prognosis level. And based on that, we develop and run systematic literature search on each one of these questions. Technically, we are doing a series of systematic reviews. Okay. Then we run regular systematic review. That means we will have 2 reviewers who are going to review or screen all the citations. And then after that, we will have 2 extractors who will extract the data. And then we will have 2 raters who will rate the quality of the included studies. And then we will review all these results with their quality and take a decision. Either we make recommendation or not. We don't make recommendations only if we didn't find any answer for the research questions, or we found some answers, but these answers are not of good quality. They are very poor quality conducted RCTs, for example. The next, we draft the manuscript with all the recommendations, and then we send these results to the external reviewers for providing feedback. When they provide the feedback, we correct or we re-edit the manuscript and submit it for publication. This is an example of one of the tables that we used for one of the clinical practice guidelines that we developed for the chiropractors for the management of low back pain patients. As you see here, we have the number of questions, we have the onset of the problem, acute to chronic, and we have the PICO format for the question, and the topic was SMT, spinal manipulation. And then the key questions, for example, the first question was for patients with acute low back pain, should spinal manipulation be used to decrease pain and increase function? And then we decided not to give any recommendation because the quality of the evidences were very poor, and so on. This is an example of one of the recommendations that we provided. The key question was, should spinal manipulation, SMT, plus other treatment versus another treatment alone to be used for back-related leg pain? The recommendation was for patients with chronic low back pain, back-related leg pain, for patients with chronic more than 3 months back-related leg pain, we suggest SMT plus home exercises and advice to reduce back pain and disability. This suggestion was based on low quality of evidence. And because of its low quality, it was conditional recommendation. And this is why we use the verb suggest. If it was of high quality, then we will provide strong recommendation. So instead of saying we suggest, we will say we recommend or we strongly recommend. You see how is the evidence control the language that you use when you provide recommendations? So at the end, what we will have is something like this. This is a summary of the recommendations that we had for the treatment of neck pain and whiplash-associated disorders, the clinical practice guidelines for physiotherapy and chiropractors. And then all what we have is this set of like half a page of recommendations. So after we finish with creating the knowledge, sorry, but someone was writing in here. Arnold, I think someone was writing here, PT patient, GP, low back pain, something. Can you see that? I think Arnold's not here. Okay.
Sorry, I'm here, but I somehow cannot turn on the mic. Let's see how I can get rid of that.
Yeah, that's weird. Someone was typing.
Yeah, I think someone override something on it.
Okay. So I will let you work on that, and I will continue if you don't mind. Thank you.
I can get rid of it.
Yeah, thank you. So at the end of creating these products, 1 to 2 page recommendations, then the next step is to use the action cycle to implement these recommendations. So the first thing that we start with is to look to the practice. We look to the practice of the clinicians. Are they practice exactly like the recommendations? If they are the same, then it's evidence-based practice. Then there is no need to do anything or implement any guidelines because they are already practicing in alignment with the recommendations. If there is a gap, then we need to implement intervention to change the practice. All right, so this is an example of the This is a recent systematic review about the physical therapist gaps in treating musculoskeletal conditions. This systematic review was conducted worldwide, and total they found 94 studies. And as you see in this table gives the percentages of the physiotherapy treatment choices that was recommended by physiotherapists. You can see here for the musculoskeletal conditions in general, about 54% of their practices of the physiotherapists were aligned with the recommendations from the literature. About 43% were not recommended, and 81% were of no previous evidence. If you look to the low back pain, you will find that 35% of the practices or the recommended treatment was aligned with the recommendations. About 44% was of not recommended care, and about 72% was based on no evidence. The neck pain and whiplash injuries, actually that was interesting because about 85% of the recommended care was used by physiotherapists around the world, and about 38% of their practices were not aligned with recommendations, and 97% were based on no recommendations. So there is gaps. Always we have gaps in practice. And whenever we have gaps, the next step is to adapt the knowledge to local context. And that really works very well in Hong Kong. But because my studies were conducted in Canada, I didn't need to do that because the guidelines were developed for the Canadian physiotherapists, for the Canadian chiropractors, for the Canadian occupational therapists. But in a place like Hong Kong, these guidelines were developed in Western countries. Therefore, we cannot just adopt them as they are because we have different training here. Physiotherapists here are trained to do acupuncture, while in other countries, they are not trained to do that. So if the recommendation is with the use of acupuncture, then this is a facilitator for them, for the Hong Kong physiotherapist, and the barrier for the Western physiotherapist. As I mentioned, I was working in Canada in these studies, so no need to adapt knowledge to local context. So we just moved to the next step, which is assessing the barriers and facilitators for the use of recommended care. And when we talk about the barriers, there are three levels of barriers. There is individual barriers at the level of the professionals, the healthcare providers. And these are such as the knowledge about the clinical practice guidelines and recent publications, the attitudes toward the use of research findings, the motivation and the skills and the self-efficacy about using recent recommendations in their practice. Also, we have organizational level, such as the availability of resources such as open access clinical practice guidelines to be published without paying any money from the organizations, the culture, whether the culture accepts new practices or not, the readiness to change, whether we are talking about small clinics or hospitals, are they ready to change the practice, especially if they have a huge or large volume of patients, and there's no time to get more training to change the practices. Also, the system. There are some barriers at the level of the system, such as the healthcare regulations and laws. I will give you an example of one of the gaps that we had in Canada and how we try to bridge this gap and assist the barriers and facilitators. There is an agreement among all clinical practice guidelines that there is a need to use stratified care approaches for the management of non-specific, or sometimes we call it mechanical low back pain. Examples of these stratified care approaches: core back tool, start back screening tool, McKinsey tool, treatment-based classification systems. There is a bunch of them. There's over 40 of them, but there are 4 or 5 of them were recommended in clinical practice guidelines. In Canada, there's a study published in 2005. Our colleague from McGill here found only 1/3 of the physiotherapists are aware of these stratified care approaches, and they were aware only of McKinsey because it was developed in 1980s and it's really famous right now. And only those 1/3 are using it. So the 2/3, they don't use it, using it, to manage non-specific low back pain cases, although we know that the usual care does nothing for those patients. That's a gap. Then we thought how to assess the barriers and facilitators to bridge up this gap. Therefore, we did this study to identify barriers and facilitators to using the stratified care approaches for the management of non-specific low back pain among physiotherapists and chiropractors in Canada. This was a qualitative study using semi-structured phone interviews that was guided by a theory, which is the theoretical domains framework. And the specified targeted behavior that we are trying to understand was whether they use stratified care approaches and tailor treatment to non-specific low back pain patients. We recruited the physiotherapists and chiropractors using purposive and snowballing sampling, and in total we recruited 13 chiros and 14 physio until we reached the data saturation, and then we digitally recorded these interviews, transcribed verbatim, and analyzed the data using thematic analysis. This is the theoretical domains framework. It consists of 15 domains, and these 15 domains are summaries of 128 theories in psychology. Just to give you a sense of the questions that we asked the participants, for knowledge, for example, we asked them, are you aware of the existence of any stratified care approaches? If they say yes, then what's this, name it. If they say, for example, McKinsey, okay, how do you use it? Explain it to us. What if you had someone with psychological problem, how you deal with that? This is the way that we are asking, and each one of these domain has 2 to 3 questions, and in total we have 30 questions. Okay. These are the key findings and the key barriers that we found for the physiotherapists and chiropractors. We found that there are shared barriers, and the chiropractors have had more barriers than the physiotherapists. The shared barriers are lack of time to get a training about new stratified care approaches. It's costly. McKinsey costs close to $10,000 if you would like to learn it in Canada, 10,000 Canadian dollars. Expertise, the availability of expertise, especially if the person is in a little town or even mid-town, like far away from the center of big cities, then it's hard to find someone with expertise to give training about these approaches. Also, we had a problem with, it was reported that by both professions that it was hard to find psychologists or psychiatric to consult those people when we have chronic low back pain patients, when they have to refer the patient to a psychologist or psychiatric to get some mental health. It was hard to find those healthcare providers. And this is one of the barriers that they found when they were treating patients with using start back screening tool. Also, we get some more barriers for the chiropractors, and these were the poor self-efficacy in using certified care approaches. Some of them, they said that we have no intention to use these certified care approaches because they had a belief that these approaches does nothing compared to the adjustment that they use in their practice. And also some of them, they were unaware of the existence of these stratified care approaches. Okay, so in conclusion, the number of barriers for chiropractors was greater compared to physiotherapists, and that reflects the nature and type of practice, as well as the prior undergraduate training that they received. Chiropractors training is usually physically oriented training, compared to the physiotherapists who have some training about the mental health and psychological and cognitive therapies in their curricula. Also, it was reported by some of the clinicians, actually the Francophone Canadian clinicians, they reported that the Start Back tool is based on a questionnaire. And this questionnaire is not necessarily available in other languages, such as French language. So that was a barrier by itself. But we thought more than that, we thought that we need to assess what are the cross-cultural barriers for the use of certified care approach, such as Start Back, tool which require the involvement of the language as a big factor. Therefore, we decided to do a study on that. But just before I go to this way, I would like to share with you what's the start back screening tool. It's a 9-item questionnaire. The first 4 questions, as you see here, are based on are asking about the physical symptoms of the patient, and the last 5 questions about the psychological symptoms. And the total score is ranging from 0 to 9. If the person score 3 or less, that means the person has low risk of developing chronic low back pain in the future because of psychological problems. If the person score 4 or more, then we look to the last 5 questions, which is the psychological subscale. If the person score 3 or less, that means the person is of medium risk, or 4 or more, that means the person of high risk. According to these sub-classifications, if the person has low risk, then we will match physical therapy treatment to those people according to the NICE guidelines, the UK guidelines for the management of low back pain. If the person has medium risk, then we need to merge between 2 treatments, the physical therapy and the psychological treatment. And if the person has high risk, then we need to refer the person to get a more psychological treatment. So to assess the cross-cultural barriers for the use of StartBack tool, we did this study to estimate the extent to which the translation of StartBack meets the translation standards and psychometric validation. And to do so, we did this systematic review over all cross-cultural adaptation studies that were targeting the StartBack screening tool. We did the search on these databases, and the search was limited between January 2008 and December 2016. We use these methodological guidelines to evaluate the translation standards, the measurement, and the quality assessment. In total, we had 1,566 citations, and we included 17 articles representing 11 languages. Now, this table represents the assessment of the translation. The translation consists of steps. The first step is forward translation that usually conducted by at least 2 translators. And then those translators will synthesize one translation, one version of the measure or the questionnaire. And then there will be back translators of at least 2 back translators. And then there will be a meeting between the expert committee, and they will review the translation, the backward translation and the forward translation. Next, there will be a pre-test of the pre-final versions among 30 to 40 low back pain patients. And at the end, there will be appraisal for the whole process. If you look to these signs, I will explain it to you. The asterisk here indicates that the step met the quality criteria. It was done properly. The question mark here, that means the method followed was doubtful or unclear. There is a methodological problem with the way that it was conducted. And the slash here indicates that the procedure has insufficient number of either forward or backward translators. And the 0 indicates that the process was not conducted at all. Actually, the majority of these translations had a problem with their translations, and only 2 of these translations met all the criteria for the good translation. And these were the Belgian French and the Mandarin translation. When we look to the measurement, we assess the content validity, internal consistency, construct validity, reliability, agreement, responsiveness, floor, and ceiling effects. Again, asterisk, that means it was the psychometric property was evaluated or tested properly. 0, it was not tested. Question mark, that means the methodology was wrong or questionable. As you see, in general, there is lack of conducting the psychometric properties in languages other than English. And when you think about internal consistency and the construct validity, and these are the most important ones, actually they were either not conducted properly or the design was questionable. When we come to the the quality assessment, we used Cosman checklist, and it consists of 14 steps. And the summary, as you see here, all of them, or the majority of them, were of poor quality, and only 2 of them were of fair quality, and these were one of the Iranian translations, because they had two translations, and the Swiss-German translation was also fair. But none of these measures were of good or excellent level of equality. So in conclusion, we found that there is a clear need for more accurate translation and psychometric validation. And also, we would like to provide a recommendation for the researchers that caution should be exercised when we get results about start-back tool in languages other than the source language, which is the English. So the next step is to select, tailor, and implement interventions. But before I go to this next step, I would like to share with you some of our previous papers that we published about them. Assessing the barriers and facilitators among healthcare providers for different recommendations. For example, the self-use of the self-management for the patients. And when in these examples, we included not only professionals, we included policymakers, we included students, and we included patients as well. Just I wanted to know that it's not only professional, we think about the professional level of barriers and facilitators. Also, we can conduct the same studies using theory on students, patients, and policy makers. So the next step after we identify what are the barriers and facilitators is to implement, first of all, to design implementation intervention, and then to implement it into clinical practice using a randomized control trial. However, before we go to that point, we were thinking of what's the best delivery mode we can provide. So how could we provide these kind of interventions? To understand or to find what's the best implementation intervention, we decided to do this systematic review to see exactly what's the recommended RCT with the delivery mode that we need to follow, so that we guarantee that what we are going to apply gonna be absorbed by the clinicians. This systematic review was conducted to summarize the evidence about the effectiveness of implementation strategies to improve the uptake and application of clinical practice guidelines, recommendations, and best practices for the management of musculoskeletal disorders among musculoskeletal professionals. We searched these databases, and we only included randomized control trials that was published in English, and we was targeting musculoskeletal professionals. We included about 15 musculoskeletal professionals, including physiotherapists, occupational therapists, chiropractors, osteopath, orthosurgeon, like many musculoskeletal professionals. And the search was conducted from inception till August 2016. In total, we found 7,904 citations, and we included only 11 studies. One of these studies was of low risk of bias, and the rest of them were between moderate to high risk of bias. If we look to the impact of the intervention strategies on the professional outcomes, we found that the majority of them were of minimal effect size range, except 3 RCTs, and these were of large effect size, over 0.8. And we noticed that all of them, the 3 studies shared similar or close delivery mode, and these were educational meetings plus local opinion leaders and outreach visit, or educational meetings plus peer assessment, or educational meetings plus reminders. And when we look to the impact, it was a huge impact. So we were thinking that if the impact on the professional outcomes is huge like this, then the indirect impact, which is the ultimate goal, is the patient outcomes, should be also big. So when we look to the assessment of the patient, of the impact of the implementation strategies on the patient outcomes, actually all of them were of minimal effect size, ranging from 0.06 to 0.31. That was weird, because the ultimate goal is to improve the patient outcomes. it's not only about to educate the professionals, it's about to improve the clinical practice. So when we looked back to the components of these interventions, we found that the only primary outcome that was used in these randomized control trials, whether effective or not, was the knowledge. And knowledge is not enough. I might know what's the McKinsey, but I don't know how to apply it, right? And I might have heard about a start-back screening tool or core-back tool, but I don't know how to apply it in my practice. So knowledge by itself is not enough as an outcome. We need to develop more outcome measures about evidence-based practice. So in conclusion, we found that these studies were of low quality of evidence and the interventions were poorly prescribed. Also, only about 50% of the included RCTs used theory, although this is implementation science. So we expected that they all will use theory. The findings of these interventions were inconsistent in terms of its impact on professional outcomes, and it was not effective for the patient outcomes. And when we looked to the primary outcome measures, we found that they only evaluated one outcome measure, which is the knowledge. That means there is a need for developing evidence-based practice measures specific for rehabilitation professionals, as we are going to implement our randomized trial on rehabilitation professionals. To address this need, we decided to develop these outcome measures, and we developed 6 outcome measures. And these are the use of evidence-based practice, evidence-based activities, knowledge about the best evidences, attitudes toward research and evidence-based practice, self-efficacy, and resources. So as you see here, this is the methodology that we followed. First of all, we searched the literature to see what are the outcome measures that are valid and reliable and used for non-rehabilitation clinicians. Actually, we found these 5 measures with a total of 181 items, and these were coming from medical and nursing literature. Because the number is very huge, 181, then we did 2 steps of item reduction. The first step was conducted by doing nominal group process. We had 16 professors, PhD candidates, and postdoctoral fellows who shared together, who went over all these items one by one and decided which one fit for rehabilitation and which one does not fit. And then we get rid of 100 and kept 81 items. The second round was based on modified Delphi approach, in which we reduced the number to 70 items, and then we distributed these 70 items into bins. That means we look to the items, and these items fit under what, and we name these items. In total, we have found that there are 2 indices fit for the formative model. That means the items form the measure itself. And these were the self-use of evidence-based practice, in total 9 items. And what do I do? In another word, evidence-based activities. And also we found about 4 set of items fit under the reflective model. That means the items have intercorrelation between each other and reflect a measure by themselves. And these were knowledge, resources, self-efficacy, and attitudes. And we run rash analysis on these 4 outcome measures. So the methodology that we followed afterwards is that we recruited recent graduates from the rehabilitation departments, from PTOT, from all Canadian universities using a national representative cross-sectional survey. We use principles of rash measurement because the number of items, as you see here, for example, in attitudes was 17 and resources 15. There are too many items. So we want to see that what are the items that fit into this measure, and then we keep them. And sometimes we will find that the response options is very wide, too many response options, so we need to reduce some of them. So this is why we use rash measurement. So in total, we recruited 128 physiotherapists and occupational therapists. The age was the mean age was 27.3 years old with a standard deviation of 6.9. The majority were females. Anglophone were about 52% and 48% were Francophone participants. About 2/3 of the sample were OT and 1/3 or 40% of them were PT. 57% of them, they were working. All right, now this is a summary of what of how we implement or how we use branch analysis. So let me explain it to simplify how you digest this information. We have two graphs. The first graph here is the threshold map, where we have in the left here, we have the items, the set of items that we administer to the participants. Here in top, we have the response options ranging from strongly disagree with a coding of 0 to strongly agree with a coding of 4. So the range of responses ranging from 0 to 4. However, not all the items will keep this 0 to 4 because some of the cells here will be having no participants or very few participants answering these cells. Therefore, we need to merge these cells together. Look for this example, the sixth or the fifth and the sixth items, we found that, or we rescored them to become 0, 1, which means that I disagree, I agree, and instead of having strongly disagree to strongly agree. And the reason, again, because these cells, we had no people or we have very few people, we had to merge them with a closed cell. This is how we rescore these items. When you look to the second graph here, which is the targeting map, we have the distribution of the items here. At the lower end, we have how the items were distributed on a hierarchical continuum from the easiest items to the hardest items. They're supposed to represent something like pill shape, normal distribution with a mean of 0 and standard deviation of 1. So in total, the distribution of the whole sample is supposed to be between -4 standard deviation and +4 standard deviation, which means that almost 100% of our sample will be distributed in these items. So, and then we have the location of the participants, where our participants scored mainly, okay? So just before I continue explaining about that, look to the item distribution. The item was poorly distributed actually, because we have here at the lower end, we have less than -4 standard deviation, very, very easy questions. And all the answers for these questions were strongly agree, and none of them were strongly disagree or neutral. Therefore, we decided to get rid of these items. On the upper end, we found a couple of questions were very hard for the participants. So almost all of them, they answered strongly disagree. So we have on the upper and lower ends, some of the items that we had to get rid of them because of the poor distribution of the items. When we look to the our participants, the mean supposed to be 0 and standard deviation of 1. However, the mean here was 1.4 and standard deviation 0.02. That means our data or our participants were shifted to the right. They were, or actually in another word, that they had positive attitude toward the evidence-based practice. These are the results for the self-efficacy. You see here, again, these are the items. This is the distribution of the option responses on 11 Likert scale from 0 to 100%. And as you see here, the items had to be rescored, all of them. And some of the items, like the first item, we rescored it to become 0 and 1. That means 0, I am not confident. 1, I am confident. I'm completely confident. So all of that depends on where the people are putting their answers. Okay, so for the targeting map here, we can see the distribution of the items ranging from -4 to 5. The distribution is good, not bad. However, we have a couple of questions here on the upper end. When we look to the distribution of the participants, we find that the mean is 0.5 and the standard deviation 1.5, which is not bad. I mean, it's a bit shifted to the right, but the distribution is normal usually. We found one of the participants who scored like all the questions 100% confident about that, which is usually this is like outlier. For the knowledge scale, we have the set of the questions here, as you see. We have the reliability, validity, systematic review, and so on. And then we have the response options, ranging from never heard the term, have heard the term, but don't understand it, have some understanding, understand quite well, and understand and could explaining to others. The range is on a 5 Likert scale from 0 to 4, and half of the questions we kept them ranging from 0 to 4, and half of them we had to rescore them, especially at the lower end, they never heard the term and heard the term but don't understand it. If you look to the targeting map, you can see here the distribution of the item was not good. You can see here at the lower end we have 4 questions, where at the lower end from -8 to -4, and the position or the location of our participants were totally shifted to the right, with a mean of 2.3 and standard deviation 1.5. That tells us also that the level of knowledge for the participants was very high. The mean was 2.3, which is really very high. And that is explainable because they are recent graduates. They were trained with master's degree. They were trained about how to use research. They conducted research. So they still have fresh information of their minds. Now, these items at the lower end, we get rid of them. All right. The next item, which is the resources, we had about 17 items. We get rid, actually, we get rid of some of them, and the response options were ranging from strongly disagree to strongly agree, ranging from supposed to be from 0 to 4. However, we had to rescore all these items, especially strongly disagree and disagree. We merged them together to become disagree. If you look to the targeting map, you can see here the distribution of our item was very good, from -4 to from -3.5 to 3 standard deviation, and the location of the participant was very good, 0.4 the mean, and the standard deviation was 1. A bit shifted, but it was very good. It was actually the typical measure that we have seen. So after we developed these 6 measures, the next step was to examine what are the individual and organizational factors that might influence the use of evidence-based practice and the evidence-based activities. Therefore, we decided to do this study in which we administered all these outcome measures for the recent graduates of the Canadian physiotherapy and occupational therapy programs. In total, we recruited people from 29 programs, and we sent the invitations to 1,703 participants, and we used these 6 measures, and we did the analysis. We did descriptive analysis and ordinal multivariate regression analysis. In total, we had 257 who participated in the survey, which is representing a response rate of 15%. The mean age was 27 years with a 3 years standard deviation. And the majority of them were females. And the language was 70% of the respondents were Anglophones and 30% were Francophones. And 53% of them were occupational therapists and 47 of them were physiotherapists. About 60% of those recent graduates were working. In total, 147 graduates. Now, this table shows you the relationship or the associations between all these measures beside the confounders, which is the age, women, the profession, and the settings where the person was working. And you can see here, whether we included or not included the confounders, that attitudes and confidence where if the person was scoring higher in their attitudes, or their attitudes was positive toward the use of evidence-based practice, or they have higher confidence, that was associated with a greater use of evidence-based practice. That was really interesting. And that also explained to us why the knowledge was used mainly in RCTs and it was not effective on the patient, because, well, it's effective for the professionals and it's important, but it was not effective in changing the practice and changing the use of evidence-based practice. And the secondary outcome, which is the evidence-based activities, actually we found that only the positive attitudes toward evidence-based practice will force the person, or will make more greater, or it was associated with greater activities of the use of evidence-based practice among the physiotherapist and occupational therapist. Now, this is time zero for the survey. We collected data also at the end of year 1, year 2, and now we just finished collecting data at year 3 to see over time how is the behavior of these measures and whether the evidence-based, the use of evidence-based will be changing over time or not. So the next step is to design a randomized control trial and implement it among physiotherapists to bridge the gap between what we know and how we practice in terms of the use of stratified care approaches. We didn't do that. We just finished working with the development of evidence-based measures. And then after we implement or we use RCTs, then we will monitor the knowledge use, evaluate these outcomes over time after 3 months, 6 months, and 12 months. And then we will follow up after a few years to see whether the practitioners are using the same implemented intervention or not, to measure the sustainability of the knowledge implementation. So just before I finish this talk, I would like to ask you a question. How long do you think it will take from us as researchers to transfer knowledge from literature to practice? How long do you think, Arnold?
Oh, it may be forever.
Actually, there is a nice systematic review that published from the University of Cambridge answering this, and they found that okay, let me share it again. They found that we need 17 years to implement the findings from research into clinical practice. It's a long, long process to be followed. Thank you.